Good afternoon, sir. I am Gaurav Agrawal from DNB from Leelavati Hospital, and I'll be presenting a short case. My case is a 7-year-old female right-handed patient. My case is a 7-year-old female right-handed patient with synostosis of the radius and ulna of the right hand with 10-degree pronation, fixed pronation, with jog of movement on either side, with 5-degree flexion deformity of the elbow, without any syndromic associations. So the patient is in 10 degree of fixed pronation. There is only jog of movement on either side. I was unable to palpate the radial head on the affected side. And
unable to palpate?
Yes, sir, unable to palpate the radial head. And it was not dislocated posteriorly or anteriorly. I was just unable to palpate it. So I was suspecting dysplasia of the radial head and inability to move the forearm in either supination or pronation.
And what is the etiology of this?
Usually it has...
No. In your patient, what history have you taken for the etiology?
Sir, it appears to be idiopathic because there is no history of trauma or immobilization or massage or no history of fever. There has been no history of any syndromic stigmata like tuft of hair or low neckline or anything. And it appears to be idiopathic, sir. It was noticed first at 5 years of age when she started going to school. But she has very good compensatory movements at the wrist and shoulder, so she really does not have a problem.
So what are the ranges of motion compared to the left side?
So compared to the left side, the elbow is from 5 degrees to 140 degrees of flexion. The forearm is in 10 degrees of pronation fixed. There is no jog of movement. However, she is able to manipulate very well with wrist and shoulder movements.
What do you think is the reason for restriction of elbow flexion or the flexion deformity of the elbow?
So it could be a dysplastic capital limb, sir. I'm not sure.
Dysplastic?
Capital limb.
That would, unless there is a dislocation or a subluxation of the
No,
radial
sir,
head.
there isn't.
Why should there be
I wasn't able to find a reason for that, sir.
Okay. And what are about the lengths, the forearm length?
Sir, the forearm length is about 1 centimeter less compared to the opposite side.
What is the reason for that?
Sir, if I'm suspecting a type 1 sort of this thing, then the radius can be dysplastic.
It could be.
So in Omer and Cleary's classification, type 1, the radius is reduced, but this thing dysplastic. There is only jog of motions. It is a membranous synostosis, and the forearm
ulna
can
is
be
normal.
Yes, sir. Ulna is normal.
Is there a ulnar variance?
No, sir. There is no ulnar variance. The styloid processes of both are in alignment, sir.
Okay, so it's then difficult to say whether it is a dysplastic radius or a short radius, right?
Yes, sir. Only on palpation that I could not get a radial head is the only reason that is why I did not
include. So the radial head is absent is what you're saying, or?
I could not palpate at the anconeal triangle, sir. I could not palpate the radial head.
It's neither dislocated nor is it palpable?
No, sir.
But is there a possibility of it being dislocated?
Yes, sir. Yes, sir. Type 3 and 4 are dislocation, posterior and anterior.
If that is so, then it could be a dysplastic radial head which is dislocated rather than a synostosis. That can also cause a restriction of movement. That can also explain our restriction of movement.
Restriction of movement, yes, sir.
So you cannot just say that based upon that I'm going to stick to my diagnosis of
dysplastic.
Congenital whatever, radioulnar synostosis is what you're saying. It could just be something else for all you know.
Okay. Yes, sir.
Right? So, sir, any questions or we go to the investigations? What would you like to do for this patient?
So I'd like to investigate the patient first, and I would like to get radiographs in anterior, posterior and lateral view of both forearms, including the elbows and wrists. Left side is normal? Yes, sir, left side is normal. But she is using the shoulder and wrist also on the left side. But when I was able to immobilize the shoulder and wrist properly, she is able to achieve pronation and supination.
Yeah, but is she right-handed or left-handed in school?
She's right-handed, sir. She's right-handed, and the right is the problem.
She's not using the left hand for writing and all?
No, sir. No, sir.
Okay. You asked her?
Yes, sir.
Which hand she's writing?
Yes,
Ask
sir,
her
yes,
again. Sure. Tell.
बेटा तुम लिखने के लिए और काम करने के लिए कौन सा हाथ यूज़ करते हो? ये वाला ना? सर राइट है.
Okay, so this is the X-ray,
So
right?
this is a
Would you-
plain radiograph in
Yeah.
anterior, posterior, and lateral view of the forearm of the right side, showing the elbow and the wrist joints. So
describe?
the radial head appears to be dysplastic.
I can't see it actually.
I can't see the radial head, sir. And so there is increased bowing of the radius.
No, that's fine, but you can start either from down up or up down,
Right,
whatever you
so,
want to describe.
so the bony prominences of the humerus are maintained. The epicondyles appear to be normal.
Yeah.
The capitulum I'm not able to appreciate very well.
That's fine.
Trochlea,
What is happening to the ulna? The olecranon, the joint,
So that too appears to be dysplastic.
appears to be shallower, no? Comparatively.
Yes, sir.
Of course, it's difficult to say, but appears to be shallower. Yeah.
So, shortened, sir.
And the proximal radius is, the anatomy seems to be distorted.
Distorted, yes, sir.
There seems to be a fusion between the proximal and the proximal ulna
radius
and
and ulna, yes, sir.
the radius and the ulna. So this is what? Is it an acquired or a congenital thing? What do you feel?
So, I'm not seeing any sequelae of any infective focus.
Okay.
And I'm not seeing any destructive changes in the joint also,
Yeah.
except for the ulnohumeral joint.
Correct.
But I would guess at a congenital cause.
Yeah, so just say that. If you feel that you're very positive about it, then just say that.
Yes, sir.
Opposite side X-ray is available?
I'm not sure, sir. I'll have to ask. दूसरे
Other
हाथ का
side?
एक्सरे है? दो है. Sir, could we please arrange?
Why am I asking for it? For the
Sir,
other side?
if it is congenital, many cases are likely to be
It's
bilateral.
Yeah, that's right. Yeah, this is the other side. So I guess it's okay, probably. Yeah, go to the normal side. What would you like to do for this patient?
Sir, she has only 10 degrees of pronation, and the mother, who was the informant, she said that she is able to hang from monkey bars and do gymnastics without any issue. The maximum issue she has sometimes is lifting a heavy school bag full of books. So right now she seems to be absolutely fine. I would recommend some physiotherapy, and she's just keeping the elbow and the wrist joint supple, sir. And no, sir, not traumatic at all. And if after 14 years of age, if she returns for cosmetic reasons, then we can offer her the option of resecting the synostosis. Sorry, sir, I just read it. I don't know the reason behind it, sir.
Synostosis, then probably there is going to be instability there. Further instability, because this dysplasia is not going to improve.
Yes, sir.
First and foremost, it's going to be almost difficult to differentiate between the radius and
Between
the
the
ulna.
radius and ulna, yes, sir.
Second is it is an area where there are a lot of nerves and vessels going around.
Yes, sir.
And third is I don't think you're going to achieve anything by doing it when the radius per se is not normal. So you're going to have more instability doing that.
Yes, sir.
So what is it that you can do which will, give her a little bit of a functional improvement in case she has an impaired functional improvement?
So in case it is impaired, if the pronation was more than 40 degrees, say, then I would recommend a rotation osteotomy for a stable hand. And this being the dominant hand, I would like to keep it in about 10 degrees of pronation after fixation.
10 degrees, yeah. So she doesn't really need much, right? That's what you're
She
trying to
doesn't
say.
need much, no, sir.
Fine.
My question is, let me show me what's his rotation like. How do
Yes,
you
ma'am.
how do you
Yes, sir.
examine?
Yes, sir. Okay. So ये हाथ ऐसे बाजू में रखेंगे बराबर. ये पेन बराबर से मुट्ठी में पकड़िए. हाँ जी. ओके बेटा. अभी नॉर्मल जैसे पकड़ते हो वैसे पकड़ो बेटा. हाँ जी. So here, sir, I'm able to see, although her wrist is compensating to keep the pen straight, when I laid a flat surface on the bones of the forearm and compared with the axis of the humerus, I got about 10 degrees of
No, show me
pronation,
his
sir.
movement. No, show me his pronation, supination.
Movement, okay. ये अभी पेन बेटा यहाँ ऐसे रखो. हाँ, अभी पेन आड़ी कर दो. सुला दो. पेन को सुला दो. देखो हो रहा है. अच्छा, अभी पेन को वापस इस तरफ सुला दो. देखो हो रहा है. So she's using her shoulder.
No. So how much of supination is this?
It's a jog of movement.
No, jog, please tell us in degrees. So what is the amount of supination he has?
So I would say less than 5 degrees.
Okay, pronation.
वापस ये पेन ऐसे सुला दो, इस तरफ करो बेटा. हाँ, हाथ इधर बाजू में रखेंगे. So again, I think less than 5 degrees, sir.
No, the pen has moved from 90 degrees to this. It's gone from
Yes,
here to here. So, how you are saying 5 degrees?
करो बेटा,
बेटा, ऐसा
वापस
करो।
सुला दो वापस. नहीं, ये हाथ इधर ही रखेंगे, सुला दो वापस. Yes, sir.
So I'm seeing 90 degrees of
Yes, sir.
pronation here.
I'd like to
So why
revise.
are you saying 0 degrees?
Yes, sir.
So how does it match your X-ray finding? No, so see, the first question is that I never interrupted in the beginning itself. Why is this not a montage of fracture dislocation? Why is it a radioulnar synostosis? What are the points to say that this is a synostosis?
So
I mean, the diagnosis comes out in the beginning when they said it, but I don't agree with that. You know,
Yes,
my
sir.
diagnosis here would be a montage here. So why is this not a montage here?
So she doesn't have any history of trauma.
Okay,
She has been able to use the hand well right since birth.
that's fine.
And that is the dominant hand, which she has
That's
never
okay. Tell
complained
me
of.
from the
No-
examination findings.
No complaint of pain, no supracondylar ridge abnormality, no diaphyseal abnormality on palpation. The styloid process.
Supracondylar ridge has nothing to do with a montage.
Yes,
here.
sir. Yes, sir.
Okay.
No diaphyseal irregularity on palpation.
Of
The-
diaphysis of what?
So, Allah.
Okay.
Then the styloid process orientation is maintained. And
Montage is an elbow fracture dislocation.
Yes,
It's
sir.
nothing to do with the supracondylar part, it's nothing to do with the distal styloid. So what are the points to tell us that this is not a type 2 Montage fracture dislocation? To my mind, she's got restriction of, he or she, I don't know, what is the boy or girl?
She.
She's got restriction of extension, all right?
Yes, sir.
She's got full flexion, but she's got restriction of extension.
Yes, sir.
She's got pronation to 90, supination to 5 degrees. Why is this not a Montage? Type 2. What are the different types of Montages?
So, based on dislocation of the radial head,
Yeah.
there is no dislocation, anterior, lateral, and posterior lateral.
No. Type 1 is where you have, so it depends on both the angulation of the ulna and the dislocation of the radial head.
Yes, sir.
They both go side by side. So type 1,
Type 1, there's no dislocation.
no, Montagia.
Oh, sorry, sir, I'll have to revise that.
Okay. So Montagia we should know, no? Because that's far more common than radioulnar synostosis. So type 1 is where you have anterior dislocation of the radial head with an anterior angulation of the ulna. Type 2 is the reverse, where you have posterior dislocation of the radial head and posterior angulation of the ulna.
Ulna.
Type 3, where you have lateral subluxation of the radial head and lateral angulation of the ulna. And type 4 is where you have a fracture along with it.
Yes,
So
sir.
this is a type 2 Montagia. So I would say you have looked at the X-ray and you have come to diagnosis because this is far less common. It's much more common to get a Montagia fracture dislocation than to get a radioulnar synostosis. So I feel that you have been informed that this is a radioulnar synostosis and you have seen the X-ray. So what are the points? Because you're not able to defend that, Gaurav.
Yes, sir.
So how do you defend it then? No? So a type 2 Montagia will present exactly like this.
Sir,
So what are the points here? The points here is that what you're measuring as pronation is not pronation. Hold that. This
Yes.
what you're measuring is compensatory movement of the wrist.
I
Right?
understand.
So if you're measuring pronation, supination, what you have to do is hold that distal, is it focused here? Hold that distal. So one is keep it against the elbow,
Yes.
against the side of the body. Hold the distal radius and ulna, not the wrist as we normally do, not the hand. But hold the distal radius and ulna and now try to supinate and pronate. You'll find that there's almost no movement here. So this shows that it is a radioulnar synostosis. If you do this,
Understood.
then how do you defend a radioulnar synostosis? Because rotation is happening at the proximal and distal and middle radioulnar joints. All right? So this movement that is there is a compensatory laxity of the wrist that they develop. And if actively the child is able to do this and passively able to do this, and this is pronation, and you say this is supination, then this is not defending your diagnosis of radioulnar synostosis, but this does.
Yes, sir.
So this is the most crucial point and that people get misled. Yeah? So in the exam, I would actually present this as a type 2 Montagia, which is far more common, rather than a radioulnar synostosis, which I would say you have looked at the X-ray and come to that diagnosis. Because I can defend a type 2 Montagia, saying that there is some pronation supination, there is a posterior dislocation of the radial head, which I can't feel, but it's probably there because that will explain why she's got no extension. And the ulnar deformity, which should be there posteriorly, has probably remodeled over time. Yeah? So you should, I would present this as a type 2 Montagia. Other possibility is a radioulnar synostosis. But to say the radioulnar synostosis, which is a much rarer condition, especially when it's not bilateral, is very difficult to defend in your exam. Then I would straight away say you have looked at the X-ray and you have come to that diagnosis. Some friend of yours has helped you with this case. Yeah?
Yes, sir.
So that's important, that you must not just go by what diagnosis has been given to us. We have to defend it from our own side. Right? Good. Okay. Any other questions from anyone? See, in the exam, it is not question of coming to a diagnosis as defending what the diagnosis is. If you can't defend it, it means your diagnosis has been told to you by someone. That's what the examiner is out to find out. Yeah.
Ma'am, short case, I was presenting only positive. Yes, ma'am.
Yeah.
Yes, ma'am. Yes.
So there are so many differentials in this. No? So Monteja is one, radioulnar synostosis is two, and exhaustosis is the third thing.
Yes.
All different causes why you have restriction of pronation supination. Out of all of them, the highest under this list would be a type 2 Monteja. Second would be an exhaustosis. Third would be a radioulnar synostosis, especially when it's not bilateral. If it's bilateral, then radioulnar synostosis will come first, exhaustosis will be second, and Monteja will be third. So Gaurav, we must understand that defending your diagnosis is far more important than coming to an actual diagnosis.
Yes,
yeah?
sir.
Yeah, so this is the globe of the humerus. This is the long line passing through the transverse long axis of the scapula, which should bisect the humeral head. As you can see, here there is more than 50% of both sides of the humeral globe on this line. The angle of retroversion is normally drawn, measured posteriorly between the long axis and the line connecting both the points of the glenoid. Here it is not too badly affected. Of course, there is a 90 degrees which they marked here, but you can see the affected side has only about 25% of the humerus anterior to this long axis, and most of the globe is lying posterior. So although this has not subluxed totally posteriorly, he's beginning to get that. And the coracohumeral distance is also reduced, as you can see on this. So you will have to do an anterior release and a posterior tendon transfer to make this come in the same lie. Yeah, and the angle of retroversion, the slope of the glenoid, there is a lot of flattening, but since they've on this plate, they have already drawn the lines. So maybe on this one you can appreciate that this is a little bit flattened as compared to this semicircular or semilunar cartilage. Yeah. So there's the next